Hello, my name is Dr.Fraum, and I'm an assistant professor of radiology with appointments in abdominal imaging and nuclear medicine at Washington University School of Medicine in St. Louis, Missouri. I specialize in oncologic imaging with a focus on MRI and PET studies. What metric do you use to determine if a patient with renal dysfunction can receive contrast for an MRI or CT scan? So renal dysfunction is an important consideration when ordering an MRI or CT scan with contrast material, though for different reasons. And the acuity of renal dysfunction is also relevant to this discussion. So let's first talk about MR contrast material, which is gadolinium-based. MR contrast material is not nephrotoxic at FDA-approved dosages, so there's no concern about inducing or exacerbating renal dysfunction as a result of its administration. Instead, the risks pertain to the effects of renal dysfunction on the body's excretion of the MR contrast material. Renal dysfunction prolongs the period over which MR contrast material remains in the body, and as a result, increases the probability that the gadolinium ions that are part of the MR contrast material will dissociate from their chelators and deposit in the tissues. Gadolinium tissue deposition has been linked to the development of nephrogenic systemic fibrosis, or NSF, a debilitating, irreversible, and potentially deadly, though very rare condition in which excessive fibrous tissue deposits in the organs and soft tissues. MR contrast material, as I said, consists of a gadolinium ion bound to a chelator that prevents the gadolinium from depositing in the tissues. Over time, chemists have developed MR contrast agents with stronger and stronger chelator binding. In fact, some of the newer agents we utilize have such strong binding that they have never been definitively linked to a case of NSF. As such, the criteria used to determine if a patient with renal dysfunction can receive MR contrast material depend on the specific agent used. For some of these newer agents, called the Group 2 agents, the American College of Radiology states that consideration of renal dysfunction is not necessary or optional. However, in practice, some institutions, including my own, still opt to administer Group 2 agents, still opt not to administer Group 2 agents. Maybe I'll back up there. However, in practice, some institutions, including mine, still opt not to administer Group 2 agents to patients with acute renal failure, as defined by KDIGO criteria, or in patients with stage 5 chronic kidney disease. Regarding MR contrast agents outside of Group 2, the American College of Radiology recommends against their use in any individuals. Back up there again. Regarding MR contrast agents outside of Group 2, the American College of Radiology recommends against their use in any individuals, 1, on dialysis, 2, with stage 4 or 5 chronic kidney disease, or 3, with acute renal failure. So to summarize, although criteria vary among institutions, patients that are not on dialysis and do not have acute renal failure will generally be considered eligible to receive an MR contrast agent. In patients with these conditions that urgently needed contrast-enhanced MRI, one of the Group 2 agents should be used to minimize risk. Next, let's discuss CT contrast material, which is iodine-based. Unlike MR contrast material, CT contrast material is thought to have nephrogenic potential at FDA-approved doses. This has given rise to the concept of contrast nephropathy. Importantly, we lack good data on whether cases of acute kidney injury that develop after a CT contrast bolus is administered are actually related to the contrast material itself versus the medical conditions or comorbidities that prompted the contrast-enhanced CT in the first place. The American College of Radiology has therefore introduced the term contrast-associated AKI as an alternative to the term contrast-induced AKI to highlight the lack of clear causality in the vast majority of cases. That said, many radiology practices screen for renal dysfunction prior to administration of CT contrast material. Importantly, there's no consensus on what degree of renal dysfunction should disqualify a patient from receiving CT contrast material. There's very little evidence of contrast-induced AKI among patients with GFRs of 30 or higher. So it would be reasonable to consider alternatives to contrast-enhanced CT in patients with GFRs below 30. In our practice, these decisions are made on a case-by-case basis, taking into consideration the urgency of the imaging indication and alternative imaging approaches that might be available to answer the same clinical question. It's also important to note that, unlike for MR contrast material, patients on dialysis can safely receive CT contrast material, assuming no other contraindication. So to summarize for CT, contrast-induced AKI is likely much less common than initially believed and unlikely to occur in patients with GFRs of 30 or higher. Decisions about whether to give CT contrast material to patients with lower GFRs should be made on a case-by-case basis depending on the clinical need and urgency.